Good afternoon, and thank you for joining us today in this Image Challenge live stream event from Retinal Physician. My name is Marianeli Rodriguez, and I will be your host today. I am a retina specialist with Vitreoretinal Associates, and I practice in Massachusetts. I have no financial disclosures. As you know, our plan is to post an image challenge each month and then discuss the diagnosis and management using this platform. We would love to hear your thoughts online. You can find us on Facebook, LinkedIn, YouTube, and Twitter, and also in Instagram. You're also welcome to write on the chat and share your thoughts with us during this event. Today, we will be discussing the case of a 55-year-old gentleman with a chief complaint of a small superior shadow in the left eye for about 2 weeks. He went to see an outside provider who diagnosed him with retinal detachment and sent him to us for evaluation and management. His visual acuity in that eye was 20/20. He had normal intraocular pressures. The anterior segment was unremarkable other than a 1+ NS, and there were no vitreous cells. On fundus examination, there was a large pigmented infranasal lesion with mild overlying subretinal fluid. There was shallow subretinal fluid up to the level of the inferior arcade. We diagnosed him with a choroidal melanoma based on the examination and imaging. So uveal melanoma is rare, and it has an incidence of about only 5 per million. And choroidal melanomas comprise about 85% of all uveal melanomas. Risk factors for uveal melanoma include light iris color, light skin color, a tendency to freckle, Northern European ancestry, welding, and very rarely also a family history of uveal melanoma. So other conditions also increase the incidence of uveal melanoma, including the presence of nevus of Oda. So the diagnosis of choroidal melanoma is clinical. These patients usually present with an elevated dome-shaped gray-brown color lesion of the choroid that have irregular margins. However, less commonly, they can also present with melanotic lesions. The clinical characteristics that should be considered when distinguishing choroidal melanomas from nevi are the thickness. Choroidal melanomas tend to be lesions of more than 2 millimeters in thickness. In contrast, choroidal nevi, they're thinner and they're flat. The presence of subretinal fluid also points to a malignant process as well as orange pigment, where lipofuscin and accumulation in the RPE overlying the choroidal melanomas is a frequent finding. Also, the presence of a sentinel vessel is associated with malignancy, and this is a tortuous and dilated episcleral vessel, which is visible overlying the melanoma. And also, secondary glaucoma is also associated with malignancy, and this is due to the mass basically pushing on the iris lens diaphragm. So other features that are associated with a benign choroidal nevi are the presence of drusen and chronicity. So after clinical diagnosis, patients usually undergo a metastatic surveillance with a CT of the chest, abdomen, and pelvis with contrast. Also, posterior uveal melanoma spread via the vortex vein to the vascular system, and 92% of metastases go to the liver. Therefore, LFTs are also indicated. The treatment for choroidal melanomas usually include radiation, either with plaque brachytherapy or proton beam radiation. Enucleation is generally indicated only for advanced melanomas that occupy most of the intraocular structures and that have caused severe secondary complications. So there's a recent approval in 2022 of tebentafusp for the treatment of metastatic uveal melanoma, and this has led to new avenues of treatment for this phase of the disease. And this is an exciting area because a lot of these patients had very poor prognosis, but new avenues are being explored. Fine needle aspiration biopsy is sometimes performed in order to look at the gene expression profile of these lesions and subsequent classification. And this may be useful in terms of providing the patient with the risk of metastatic disease moving forward. So we referred our patient to the Ocular Oncology Center in Boston, where he received proton beam radiation, and he's currently stable. So thank you for tuning in today. And you can leave us a comment online via our multiple platforms. And we hope to see you again in about a month as we discuss another interesting case. Thank you.